There is no doubt that the experience of breastfeeding is essential in the establishment of the bond between the mother and the child. Breastfeeding contributes significantly to the development of the infant, as the mother's milk is the principal nutritional source for the child's initial 6 to 12 months. However, when it comes to treating the mother for mental health issues, maintaining a balance between meeting her health needs and safeguarding the infant's safety from the side effects of psychotropic medications still remains a big challenge. Peace and light obstetricians and gynecologists. My name is Dr. Sonia Fulgham, and I am a clinical psychologist currently working on a master's degree in pharmacology. Today, I will be presenting about psychotropic medications used during breastfeeding and focus on antidepressants, analytics, and antipsychotics and mood stabilizers. Antidepressants are perhaps the most commonly prescribed mental health drugs. First, it is important to note that infants respond to an exposure to antidepressants through breast milk, which varies depending on the antidepressant category. Although there is various side effects that could result from the diffusion of SSRIs to the infant through the mother's milk, the most common ones are irritability, sleep disturbances, and colic. As for monoamine oxidase inhibitors, there is negligible data on their use during lactation, although the potential for serious interaction with certain drugs and food have led to recommendations that they should not be used during lactation, and particularly first generation MAOIs should be avoided for breastfeeding mothers. There is a significant amount of data to support the safe use of tricycline antidepressants, such as despromine and nortriptyline, in breastfeeding mothers. Nonetheless, there is still potential for side effects, such as persistent pulmonary hypertension in infants, infant respiratory depression, and when it comes to norepinephrine dopamine reuptake inhibitors, their outcomes during breastfeeding remain considerably unreported. Altogether, no adverse consequences have been reported with their use. Finally, data about the use of serotonin norepinephrine uptake reinhibitors remain scantily, and those that have been observed, the reported side effects include tachypnea and pulmonary effects such as persistent pulmonary hypertension. Look at analytics, and especially benzodiazepines. They have been shown to cause quite a number of side effects in infants, and these include weight loss, infant sedation, irritability, lethargic, hypotonia, CNS depression, cyanosis, sleep disturbances, and excessive periodic breathing. Due to the paucity of data available about them and the potential for considerable infant sedation effects, zyplicone and zolpidem should be avoided. The routine prescription and usage of antipsychotics or atypicals, which are also popularly referred to as SDAs or serotonin dopamine antagonists, during lactation is discouraged for various reasons, but majorly due to the high risk level that they pose upon the infant. Some, like Klonopin, actually carry a manufacturer's warning against the usage during lactation. Some of the potential risks include anergenic effects, which have been associated with ziproxidone, olazepam that has shown to carry the risk of somnolence, jaundice, heart murmurs, and cardiomegaly. In the case of Klonopin, some of the side effects that have been reported include agranulocytis, restlessness, decreased suckling, cardiovascular instability, sedation, seizures, and irritability. While the ones discussed in this slides are simply examples of antipsychotics and the risks that they carry when using during breastfeeding, some of them, like chlorpromazine, have been considered, whereas there is a lack of data about the usage and effects of some antipsychotics like risperidone. The effects inform the council to exercise caution if they just must prescribe. Mood stabilizers are interchangeably referred to as anticonvulsants and antiepileptics. There is comparatively more data about the use of mood stabilizers during breastfeeding than there is in DRIs. In terms of potential risk, general data pertaining this category shows common risks and side effects. These include cases of vitamin K deficiency, anemia, thrombocytopenia, and increased risk of hepatotoxicity. Now let's take a look at some of the recommendations regarding mood stabilizers. Some mood stabilizers, and especially carbamazepine and valproate, have been regarded as being comparatively safe with use of breastfeeding mothers. Still, you need to exercise caution when prescribing. Gabapentin has also shown to cross 100% of breast milk. As such, it should be avoided altogether. Even with the type of mood stabilizers that are considered to be relatively safe for the use during breastfeeding, it is strongly recommended that you monitor the liver function, palates, and serum levels. Before prescribing medications for lactating mothers, there are several precautionary considerations that are necessary to be made. Of course, the attributes of the drugs and the effects that it has on the body are primary. In this case, the more lipid soluble and the less protein bound a drug is, the more weakly it is, and therefore the higher the possibilities it will diffuse into the breast milk. Even small medications amounts could accumulate into toxic amounts in the infant. Infant related factors include weight, age, genetics, elimination, and metabolism, and absorption influences the effects on the medication and the child. For instance, the infant has some immature metabolic liver enzymes that make it difficult for it to break down the medication. The FDA has categorized various psychotropic drugs based on their risks to the fetus, which you can find from the FDA MedWatch program online. The categorization include up to the 5 lactating risk categories, with L1 comprising the safest medication and L5 comprising the drugs with contraindicated risk factors. As I had mentioned in the previous slide, The FDA has various categories for medication, and psychotropic drugs are no exception. Like all other drugs, the FDA has categorized psychotropic drugs into five categories based on the risks that they pose to the infant during lactation. Now let's take a look at each of these lactation risk categories and the data available on the risks. Psychotropic drugs classified as L1 are considered to be the safest. Data available for L1 drugs show no adverse effects have been observed. Data available from controlled studies does not demonstrate any risks. The potential for causing harm is remote. And finally, the drugs are not orally bioavailable to the infant. L2 psychotropics have shown acceptably safe levels. L2 drugs have not shown any adverse effects, but the number of breastfeeders involved in the studies are limited. L3 are regarded to being moderately safe. They are characterized by the lack of controlled studies involving breastfeeders. Potential risks, which means that they should only be administered when the potential benefits that they are associated with justify the risks they pose on the infant. Psychotropic drugs in the L4 category are considered to be potentially hazardous. Their traits include proven risks to the production of breast milk and to the infant is backed up by data. The benefits that the mother stands to gain from taking them could be acceptable in spite of the risks that they pose to the infant. L5 psychotropic drugs are termed contraindicated. This is because there is significant documented risk to the infant. There is considerably high risk that administering them will result in significant damage to the breastfeeding infant. The risk that comes with taking L5 psychotropic drugs clearly outweigh every possible benefit that might occur from breastfeeding. Before concluding my presentation, let's take a look at some of the key takeaways. First, all psychotropic drugs administered to breastfeeding mothers carry some levels of risk to both the infant and the mother. However, some of them are riskier to administer than others, to the extent that some manufacturers have issued warnings against the usage of drugs by lactating mothers. The traits of both the mother and the infant are crucial to the determination of the drugs to be administered. For example, the age and the weight of the infant, as well as the body metabolism, should be factored in while making decisions to administer psychotropic drugs to the lactating mother, since this essentially influences the risk level of the drug and the impact that it has on the infant. In addition, there is a need for monitoring of reactions and effects of the psychotropic drugs on the infant and the mother as well. Finally, the risk-benefit balance should be such that the benefits associated with prescribing psychotropic drugs to mothers outweigh all known and potential risks on the infant and the production of the breast milk. So there you have it. I would like to take this time out to thank you for being a part of my audience and to have an amazing day on purpose. And continue to be great. Peace and light.